Start, or shall we wait for another 5 minutes?
Good morning, everyone. Today's topic is transposition of the great arteries. It's a block of 6 sessions that will cover, I hope, all the topic. And Vidya presenting today's first part of that, anatomy, physiology, embryology, and echo. So please, Vidya, you can start.
Good morning, everybody. I'm sure everybody knows who I am. And for those of you who don't know me, I'm Vidya, one of the cardiology registrars. So as Oleg said, this is a few blockbuster of the few topics that we are discussing in the last few months. And I am going to be talking a bit about transposition of great arteries today. So just bear with me. Right, okay. So oops. Sorry about that. So what is TGA? TGA basically is defined as transposition of great arteries where there is ventricular arterial discordance. What it means is basically the aorta. As you can see on this figure, the aorta is arising from the right ventricle, and the pulmonary trunk is arising from the left ventricle. Also, it can be associated with atrioventricular discordance, where the right atrium is connected to the left ventricle and the left atrium is connected to the right ventricle. So the pulmonary trunk is coming off the left ventricle, and the aortic trunk is coming off the right ventricle. So essentially, that is the congenitally corrected TGA. It was first this morphology was first described by Bailey in 1747, and then actually Farrick coined the term TGA. There's more to it about the history. I'm not going to go into it. So let's talk a bit about how common is it. It accounts to about 5% of all the congenital heart diseases, 10% of the neonatal cyanotic congenital heart diseases. And how often does it happen? About 2 to 3, 10,000 live births. And this figures are within the Europe. It's kind of slightly different with the American figures anyway. And 10% of these, the kids with TGA have got extracardiac abnormalities. And most commonly, they are kidney problems with the kidneys or cerebral malformations. And that's what has been described in the literature. Males are more commonly affected than the females. And I think about 1.5 to 3 times more than the females. Why this is, we don't know. And it accounts to 35% of all the conotruncal abnormalities. That being tetralogy of Fallot, DORV, so that spectrum of conditions. So this is one of them. This is the extreme part of it. So pathogenesis, basically looking at why this happens. So before we kind of go into why TGA happens, I think it's worth having a little look at what the normal cardiac development is. So the heart develops from the mesocardium quite early, in the quite early stages. The crucial stages, I shall start describing about what happens with the heart from day 19, which is when the embryonic endocardial heart tubes are formed. So this slide basically telling you that the stages of the embryonic development. Are you all still with me? It feels a bit strange that I'm kind of talking to the computer screen.
We can hear you, everything is fine.
Okay, thank you. So it starts off with early embryonic heart fields, then moves on to forming endocardial heart tubes, and cardiac looping happens, and then cardiac septation happens, followed by outflow tract development, and of course, then it's the valves to kind of develop next, and then finally the conduction system. So the heart is fully up and running by about day 50 to day 60. The reason I put these two arrow marks is this is where we are kind of interested in as, you know, with regards to development of TGA. I'm going to try. So this is basically the kind of the time framework as to what happens during the development of heart. As you can see by the week one, straight away it starts off with some precardiac cells in the primitive streak. And then by about day 19, you can see that there are heart tube. The heart tube starts forming and they start kind of folding into midline. There are two heart tubes on either side of the embryo, and then that kind of fuses together to form a single heart tube. And the heart tube actually by day 22 kind of has got a cranial end and a caudal end, and the blood is pumping through the venous end and comes out of the arterial end. And I'm going to show the picture in the next slide anyway. And then in between week 4 and week 5 is the heart looping that happens, and which is again very crucial for the development of TGA. And as you can see, by day 60, the heart is fully developed and there is a conduction system in place. So this is what I was talking about, the heart tube, and you've got the sinus venosus end. This is where the venous blood kind of comes in, and this forms the primitive atrium and has got a little canal that goes into the primitive ventricle. And then there's a cornoventricular canal that leads into the bulbous cordis, and then the truncus arteriosus. So essentially that forms the atrium, that forms the ventricles, and a part of this as well forms the ventricles, and then that is the arteries, the great arteries. So I'm going to try and play this. Sorry, I've just moved on to kind of more relevant bits of development of TGA. Okay, so I thought that was going to be very helpful as to how we kind of about understanding about how TGA kind of ends up happening. So sorry, I've got a few extra slides just in case that didn't work. So there are two theories that have been postulated in development of TGA. One of them was by Gould and Edwards. Basically, that's called as the infundibular theory. So where there is the normal clockwise, lack of normal clockwise rotation of the aorta, if you're kind of looking at the heart from above, the rotation of the aorta doesn't happen, clockwise rotation of the aorta doesn't happen. And also they have postulated that there is an abnormal resorption or underdevelopment of the subpulmonary conus, but the subaortic conus kind of completely persists, and that leads to the development of TGA. Whilst this theory kind of explains quite very well the other anomalies that are associated with TGA, like the VSD, and of course the double outlet right ventricle. So they're all kind of the excess. The TGA is an extreme case of this. It's a spectrum starting from VSD going on to the tetralogy of Fallot, and then the double outlet right ventricle, and then to the TGA spectrum. So this theory kind of explains that bit. But however, you know, the way the kind of the vessels are parallel in TGA, it doesn't explain that. So the De La Cruz actually postulated another theory. So basically, they kind of, as you can see from the, as you've seen the previous video, where you could see the septum that kind of divides the truncus arteriosus, it kind of spirals out, and that spiraling doesn't happen. Instead, the septum is more linear, and that leads to the development of TGA. So normally TGA is not kind of associated with any, it's rarely associated with any kind of genetic syndrome, like, you know, Down syndrome being most commonly associated with AV canal defects, and of course the tetralogy of Fallot is associated with DiGeorge. So unlike like that, TGA is not associated, but there's one condition that is associated with TGA, which is basically called as the heterotaxy. So this is where the other organs in the body do not kind of rotate and exhibit the similar kind of left and the right asymmetry, which all the mammals exhibit with different organs in the body. So the heterotaxy syndrome is associated with situs inversus, dextrocardia, and mesocardia. Now, one of the theories implicated in the development of TGA as well is the nodal gene, and this plays a very important role in bringing this left to right asymmetry and also kind of rotation as well. And studies have shown that FITX2 mutation as well kind of leads to conotruncal abnormalities. And there's another gene called as a ZIG3, which is implicated in the heterotaxy. So except for heterotaxy, the rest of the things that I have listed on this on this slide is basically associated more with TGA along the DORV spectrum and tetralogy Fallot-like presentation. So the risk factors that are associated in development of TGA include maternal diabetes, and of course maternal infections, and ibuprofen. I was quite surprised to see ibuprofen was one of them. Anti-epileptics is very well known teratogen anyway, and also the you know, the hormonal therapy can cause TGA. Are you all with me? Any questions so far? Hello?
No questions.
Carry on, Vijay, all good. Carry on.
Yeah, it feels a bit weird because there's no, I can't see the response. Sorry.
We're listening. I'm listening.
Okay. So with TGA, so Sorry. So with TGA, the TGA is kind of now classified. I mainly classified this into three easy because it's easy to understand the anatomy. Sorry, why the slides are not slipping anyway, it's fine. DTGA, there is the complete TGA where the interventricular septum is intact, and 50% of this condition is isolated. Then the TGA is associated with different other cardiac abnormalities that includes VSD, PDA, or with with the right ventricular outflow tract obstruction or left ventricular outflow tract obstruction. Now, in TGA, the right ventricular flow tract obstruction would include your coarctation and hypoplastic arch, that spectrum. And of course, the left ventricular outflow tract obstruction would include your pulmonary tract problems, pulmonary trunk problems, which include pulmonary stenosis and pulmonary atresia. Now, 40% of the cases of TGA are associated with VSD. Now, the other entity is LTGA, which is basically corrected TGA, and this accounts for about 1% of all the other congenital heart diseases. Oops. So the pathophysiology includes in DTGA, there are two parallel circuits. The deoxygenated blood continues to circulate systemically. As you've noted, the aorta comes off from the right ventricle. So basically, the blood is received by the deoxygenated blood is received by the right atrium by the IVC and SVC, and then moves through the mitral valve into the, tricuspid valve into the right ventricle and then into the aorta. So the systemic circulation is deoxygenated. And then the blood from the lungs come into the left atrium, goes into the left ventricle, and then goes back again into the lungs because the pulmonary trunk comes off the left ventricle. So there is hyperpulmonary circulation. There are two independent parallel circulation, and hence why if there is no mixing, there's, it's it is lethal to life anyway. So the mixing can happen at different levels, and that could be between the atrium, which is atrial septal defect or PFO, and it could happen at the ventricular level at the ventricular septal defect, and it can happen at the great arteries where the PDA, there is a PDA connection. Now, without any of these connections, of course, the survival and that also kind of influences at what time and what kind of how the baby is present as well. Now, as opposed to this, in the corrected TGA, because the left ventricle kind of gives off the left ventricle is transposed onto the right ventricle, and the aorta comes off actually from the pulmonary artery comes off from the left ventricle and is in line with the right atrium. Still, the normal circulation happens, and oxygenated blood can go across the body normally. So the presentation doesn't necessarily happen in the neonatal period. The presentation happens later in the life because the right ventricle cannot cope with the systemic pressure. So this is a little video to see what happens in the circulation because I can talk. So basically you can see that is the right ventricle, and you can see the aorta coming off there. So that is the deoxygenated blood from the right atrium coming on. Sorry, having a bit of a problem with the working of this. So that's the aortic trunk, that's the pulmonary trunk. And deoxygenated blood coming into the right ventricle there. So this is the normal circulation, what happens in the normal heart. Right ventricle into the pulmonary trunk, and then from into the left ventricle into the aorta. So this is our normal circulation. But in TGA, you can see the aorta is coming off from the right ventricle, and the blood goes, that is the deoxygenated blood going into the aorta to the rest of the system, and oxygenated blood coming from the left atrium into the left ventricle, and then goes into the pulmonary trunk. So that will be the problem with, so unless there is a mixing happening there, or there, the survival is difficult. So how do these patients present? So it could be either antenatal diagnosis. These days we can kind of, apparently there's still the pickup rate in the prenatal diagnosis is still 50%, but it does make a huge difference as to how we manage these kids after they're, when they're born. If we know that the child has got a TGA, we can plan for, the emergency procedures that are needed, and I shall discuss that in future. So postnatal diagnosis, again, depends on how the child presents. Again, so the DTGA usually presents with cyanosis within the first 24 hours. That is because, and again, this is influenced by the amount of mixing that happens either at the atrial level or the ventricular level of the PTA. So the babies with intact ventricular septum, again, kind of tend to be a lot more sicker, and the atrial communication as well influences as to how sick they can be at the time of birth. So the second spectrum is actually TGA. We've got VSD. So basically, there's quite a lot of mixing happening between the right and the left side. These are proportion of patients who actually present with tachypnea or failure to thrive, and they might not necessarily be cyanosed, depending on the amount of mixing that happens at the ventricular level. But instead they develop more signs of pulmonary overcirculation, which develops over a period of few weeks. So they can present with congestive cardiac failure like symptoms, failure to thrive in about 3 to 6 weeks of life. And of course, if left for a longer time, they are at the risk of developing pulmonary vascular disease as well. Then again, there's another spectrum of patients who develop outflow tract obstruction, and the most common outflow tract obstruction is the pulmonary trunk, which is left ventricular outflow tract in TGAs. So they can have either pulmonary stenosis or pulmonary atresia, and they again kind of present like babies with tetralogy of Fallot. So with cyanotic spells or with cyanosis, and of course cyanotic spells, and may develop depending on again how much of mixing is happening, how much of pulmonary flow is there. They can develop congestive cardiac. They can develop failure-like symptoms, like we talk about the pink Fallows. So investigations-wise, how are we going to investigate these children? So I'm going to kind of stick to strictly about the cardiac investigations. So the chest X-ray is, these are just, the echocardiography is the standard of initial investigations that helps us to prove one way or the other. But I'll come to that later because I've got lots of pictures to show. Investigations wise, chest x-ray does show agonist link. That is partly because of the way the arteries are arranged, and both the atria are on either side. So the mediastinum seems to be quite small, and the heart itself looks quite big, and which is why it gives the appearance of an agonist link appearance. And the electrocardiography, the ECG, it can show right axis deviation, anything between 90 degrees to 200 degrees, can show right ventricular hypertrophy, and in babies with VSD and PDA as well can exhibit biventricular hypertrophy changes on the ECG. So of course, CT scan and cardiac MRI are the other things to kind of, once we've done the echo, then to get further more details about, say, coronary artery morphology, if you're not able to pick it up on the echo, to delineate more of a cardiac anatomy. So that's when the CT scan will be done. Again, as I said, with microscope, with the chromosomes and microarray, I think the ones with the tetralogy of Fallot and DR, we kind of think need more of chromosomes, because they are the ones that are commonly associated with DiGeorge syndrome, and trisomy 8 and 18 are as well kind of implicated. So, moving further about echo. So what are we doing, looking when we're doing echocardiography on these children? So as I said in my talk earlier, the TGA is associated with heterotaxis syndrome and problems with the situs. So we kind of look for the situs when we're doing the echo. And then we're looking at whether there is an ASD present or not, whether there's VSD, then again, basically looking at the various mixing levels as well, and coronary artery pattern, and what is the outflow tract pattern like, and the relation between the aortic and pulmonary valve as well, because these are the things that have kind of got implications as to when and how quickly do we get into the management of it, management of the condition itself. And of course, it's got implications about how the surgeons manage it on the table as well. So subcostal views, we look for, again, situs that we're looking at the ASD and the size of it, the flow across the ASD, and then again, looking at the VSD and the size of it, and to define the ventricular morphology. Obviously, CCTGA is the one that's kind of associated with the left ventricle being on the right, so we need to identify that. And then, of course, looking at the subcostal views also shows the parallel great vessels. Normally, on a normal echocardiogram, you see the great vessels actually crisscrossing or crossing over, but in TGA, you can see them being parallel. So that is a picture of showing, that is the normal situs. You can see the aorta there, and the IVC onto the right, aorta to the left there. But in situs inversus, you can see the aorta there and left, IVC onto the left. So this is a video that shows the ASD communication. So there we go. With left to right flow there. So subcostal views, what we were talking about, being the arteries being parallel. So that's the right ventricle giving out a parallel. Normally, you don't see this kind of pattern. And in the parasternal long axis views, we look at the parallel. The vessels are parallel. I have got a video that I'll show you in the next slide. But here you can see the left atrium here goes into the left ventricle and then goes into the pulmonary artery here, and you can even see the branching of the pulmonary artery here. And that's the right ventricle. I can't see the right, of course, the outflow from there. So this is one of our patients actually. So that is the left atrium. Sorry. And that's the left ventricle, and that you can see both the vessels. Normally you don't see this in the normal echocardiogram. You don't see this picture, this kind of a picture. You can see both. That's the aorta. So the next is actually, this is the parasternal short axis view, where you can see the aorta here. This is a normal echocardiogram, echocardiogram on a normal child. There's a parasternal short axis view. That is the RVOT. You can see the pulmonary artery there in the aorta, and you can see the relation between the pulmonary valve is there and the aorta is there. So as opposed to in a TGA, that is the aortic valve, and that is the other thing in the parasternal short axis view as well, is you don't see both these valves in the short axis parasternal view in a normal scan. So normally there's the aortic valve, and as I showed in the previous picture, you just see the right outflow tract rather than the valve itself. As you can see here, you can see both them. And the aortic valve is almost anterior. So let me play this. And how do I identify that this as a aortic valve? You can see the coronary arteries there. So again, we're looking at the coronary artery pattern as well, because that does have an effect on the prognosis of, following the surgery. So different kind of patterns have been discussed, just as a diagram to show. I think the ones with a single ostium, like single coronary artery, and the ones inside the cardiac muscle itself, they are associated with a significant mortality during the switch operation. So coming to the apical view, what are we looking at? We are assessing the function, and of course we are looking at the valvular function as well. And of course you're looking at the outflow tract. And this picture does show that is the left ventricle, showing off the pulmonary trunk, which is kind of branching there. So again, TGA is very commonly associated with VSD. As we've discussed, about 40% of the TGA do have a VSD, associated VSD. And when we look back into the development as well, the septum and the spiral septum contributes to the perimembranous bit of the VSD. So malalignment of this ends up kind of creating a VSD in TGA, and that explains as to why we see that very often. And this is a parasternal long axis view where you can see the left atrium, left ventricle, and of course the MPA is coming off the left ventricle there, and you can see the VSD. And then moving on to CCTGA, what happens? So you need to kind of describe the left ventricular. The way you identify this CCTGA is by describing looking at the ventricular morphology. The right ventricle has got a moderator band here. And of course, the left ventricle, which I've not been able to get a picture of, does show the papillary muscles as well. So that is on the parasternal axis view. And you can see here the pulmonary trunk coming off the left ventricle and aorta coming off the right ventricle. So management-wise, what are we going to do? So in a neonate with an intact ventricular septum with little mixing of blood at the atrial level, they present quite significantly cyanotic. So they end up, you manage them with the ABC approach, then assess their acid-base status So basically doing a capillary gas, looking for hypoglycemia, correct all the electrolytes as well, and start them on a prostaglandin infusion to keep the patent ductus open, and move them over for an emergency palliative surgery that includes the septostomy to widen the atrial communication. Now, I've just kind of concise my surgical management, because I'm sure we're going to have a talk in future about how they're going to be managed surgically, and I let my surgical colleagues do that. So surgically, the simple TGA usually gets corrected if there is good mixing and the child is stable. The arterial switch operation happens within the first is recommended between first and the third week. We normally tend to do within the second week, don't we? And the TGA with PDA, BSD, and mild PS, again, if they are stable, then you do the there's a mixing here, so we just kind of do it between the first and the third week. And TGA with VSD and severe PS, again, there are 3 options. So initially do a palliative surgery where we create a shunt so that the blood flow, there's blood flow to the systemic as well as the pulmonary area, and then followed by PST with a Rasterly procedure or a REV procedure or a Nicola. I'm not going to go into the details of what these procedures are. TGA with large VSD and subaortic stenosis, they tend to have a BT shunt and then a Damas, Sanodamas, Damas shunt and VSD and RVPA conduit at a later date when they're about 1 to 2 years old. So complications following the surgeries, you do expect them to have arrhythmias, and you anticipate obstruction and leaks through the battle. They've had a Rasterly procedure, and pulmonary artery stenosis, and of course coronary artery stenosis, issues with the aortic root, dilatation and regurgitation. And this is what we kind of look for in monitoring them long term. So in summary, TGA is quite a severe congenital heart disease due to a problem with the spiral migration and ventricular looping. The management depends on the level of mixing. It could be a palliative procedure like an atrial septostomy or a shunt, depending on how soon they're present. And of course, the other things that we need to be aware of, the associated anomalies and coronary pattern as well. And antenatal diagnosis definitely has reduced the mortality quite significantly, because we can anticipate this and arrange for the child to be transferred across to a tertiary unit as soon as possible to enable the septostomy. So that's my talk. Thank you very much. And if there's any kind of questions, I'm happy to take.
Hello?
I can't hear you.
It's me, I'm hearing myself bad. Anyway, Vidya, thank you very much. It's a nice talk. But one thing we missed to discuss today is in associated anomalies, TGA can have isolated coarctation.
Okay.
And TGA can have arch abnormalities and importantly, Taussig Bing anomaly. That's something we didn't touch today.
Okay.
And the second thing is about antenatal pickup.
Yeah.
I think maybe it's since you raised it, it may be a good idea to do an audit in our department and then see how many of our TGAs are picked up antenatally.
Well,
because I think it's pretty high.
Yeah, I think I've got the data at the moment, really. So we can kind of put it into the formulate. Yeah.
Okay. Yeah. Well, what is our pickup?
Sorry?
What is our pickup rate, antenatal pickup?
No, I have not looked into the data. I'm just collecting the data at the moment. So yes, once I've kind of analyzed, I can kind of give that, feedback.
That's good. Thank you. Otherwise, very nice.
Any other questions?
Yes, in saying you're concluding, and then you're going to stop recording. Just if anyone else, somebody else has questions, we can say that way.
Thank you very much, everybody.
Thank you, Vijay. Thank you all.
Thank you.
Thank you. Thank you.